All right. Hi, everybody. Thanks for joining the September Journal Club session. We're going to be going over guidelines and a few journal articles. My fellow Carver is going to be joining us and helping us proctor the journal articles aspects. And we can have like a little meet and greet after if anybody wants to chat about cool wilderness medicine opportunities they're involved in or any cool cases they've had recently. But with that being said, Kristen, take it away with the guidelines.
All right. All right, so kind of wound care guidelines based on the WMS kind of practice bulletin. Is what we'll be talking about today. And this is back from 2014. So of course there might be newer data and evidence since that time. But this is kind of what we currently have. I have no conflicts of interest. There will be several pictures I just took off the internet for those who are visual learners and kind of want to see what some of the different products are that we'll be talking about. But I have no kind of interest for any of these specific products. So just kind of a roadmap. So we'll be starting about taking a history and a physical for these wounds, and then talking a little bit about some anesthesia, immunizations, mainly tetanus and rabies, getting good hemostasis on a wound, talking about lacerations, abrasions, blisters, burns, infections, and then finally evacuation. So they have kind of grading evidence in this practice bulletin. And so essentially grade 1 is really strong recommendation. Grade 2 is a little bit of a weaker recommendation, and essentially how the risks and benefits are kind of weighed out. And then we have A, B, and C, and that's just the quality of evidence that's there based on either randomized control trials or observational studies. So 1A, of course, being your strongest, and 2C being kind of weaker recommendation and lower quality evidence. So essentially the bottom line is to stop the bleeding, keep the wound clean, and then maybe you might be able to close a little bit more than you thought, and then kind of using some common sense in terms of evacuation. So when you have a patient that's coming in with a wound of various types, kind of a couple things that you might want to think about with your history. So if you're using, say, the sample mnemonic for taking a history, so signs and symptoms, paying attention to how much pain they're in, what type of infection risk, or does it already look like there's an infection kind of brewing in it? And for acute wounds, how much blood was lost? And are you currently still bleeding? For allergies, thinking about any allergies to antibiotics, either if you have antibiotics where you're currently at, or for kind of transporting a patient if they might need antibiotics in the future. For medications, paying a close attention to steroids, immunosuppressants, basically anything that could, anticoagulants that could either cause them to continue to bleed or impair wound healing or change the risk of infection. From a past medical history, so diabetes, again, impairing wound healing, tobacco use, your bleeding clotting disorders, and then looking at tetanus shot, when their last tetanus shot was, mainly thinking about, has it ever been done, less than 5 years, less than 10 years. And then for a last meal, that's primarily if you're gonna have to transfer the person, or if they have lost a significant amount of blood, thinking about kind of rehydrating to help replace some of the fluids lost. And then finally, for events, kind of the mechanism of injury, if there's an animal present, kind of what type of animal, and getting some data on that. For your physical exam, I'm going to kind of keep it in 3 main things. So one is clean, and this doesn't necessarily have to be like sterile clean, but just, fairly minimally dirty. So like a knife wound might be considered a clean injury. Then you have more contaminated where there might be some dirt or other things. And then finally dirty. And so that includes your wounds that are kind of more than 6 hours and really kind of a very grossly contaminated type of wound. For anesthesia, so they do recommend pain control. They primarily talk about more local pain control. So, first off with lidocaine, and you might be familiar with using that for kind of wounds or suturing lacerations. This is something that you do have to inject, so that's one of the downsides of it, but it does provide really good kind of anesthesia coverage. Epinephrine can help the lidocaine stay a little bit more locally, but you're going to want to avoid that, of course, in toes, fingers, nose, kind of earlobes, penis type of area. An alternative, if you're not carrying kind of that needle and syringe, would be some topical lidocaine. We use this often in our pediatric patients. The big downside to this is that it can take 20 to 30 minutes for it to kind of kick into place. So it's something that you have to put on and kind of wait a little bit of some time for it to come, but you can get it kind of over the counter, and it might be a little bit more portable depending on what type of situation you're in. Moving on more to your immunizations. So the first one being tetanus. And so tetanus you can get from the soil. And so kind of thinking about any injury that's kind of significantly contaminated with kind of dirt. And so kind of when you're thinking about immunizations and kind of their risk of getting tetanus, there's kind of a couple different things. So one, have they ever been vaccinated? Or is their last dose kind of more than 10 years ago? So if they've never been vaccinated, their dose is more than 10 years ago, the recommendation, whether you have a wound or not, is to get the toxoid injection. So that would be like your Tdap vaccine. If you have a clean wound, fairly low risk, so you don't need any prophylaxis there. Now, if you have a really dirty wound and high kind of concern for tetanus, again, if you haven't been vaccinated ever, or it's been more than 10 years, not only do you want the vaccine, but you also want the immunoglobulin. If it's been between that 5 to 10 years, you just need the vaccine. And if you're less than 10 years, you're golden. So another kind of interesting thing would be if you have access to antibiotics, that may decrease kind of delay kind of the response of getting a tetanus clinical infection. So that can be helpful if you don't have access to the immune globulin or the toxoid vaccine. Then going on to rabies. Now here in the US, we really see rabies in kind of bats, raccoons, skunks, and foxes. In other parts of the world, dogs are still a big carrier of this. And so if you have kind of a bite with one of these kind of common species, you should start to have a little bit of a concern about the possible infection of rabies. Again, it's fairly low kind of here in the US, but something we should still have in the back of your mind. So out in the field, before you have access to anything, cleaning with soap and water is a great idea. If you have kind of either the iodine or like chlorine dioxide, so that's like the potable aqua kind of tablets, those can also work really well. And we know that that decreases the risk. And in terms of closing this wound, you're going to want to wait at least 4 days prior to thinking about closing this. Once you have access to the immune globulin and the vaccine, you'll want to put the human rabies immune globulin, that's the HRIG, into and kind of around the wound. And then they're going to get kind of various doses of the rabies vaccine. Kind of an important thing is that you can 24 to 48 hours in terms of getting treatment. So it doesn't have to be kind of right away. And it's really never too late to treat as long as they don't have symptoms, especially because for the vast majority of cases, this is a fatal disease. All right, so moving on to hemostasis. So kind of common sense, kind of direct pressure is going to be your #1 control to get the bleeding stopped. You know, you don't want like this huge stack of gauze. You really want to kind of try and apply as much pressure kind of directly to the wound. Once the acute bleeding is fairly well controlled, you can then go to a pressure dressing to help with the maintenance. And so kind of the picture here shows like the Israeli type of pressure dressing. It's common in the military and it works very well. In terms of elevating the extremity, that's a 2C recommendation. So really kind of might help, really no harms too much, but shouldn't be the main thing that you focus on. And then kind of the different hemostatic agents, for example, like a quick clot, that might be effective, especially if kind of that direct pressure just isn't doing enough. Or if you're thinking they have lots of risk factors for ongoing bleeding, you could try something like that. The downside of that is that's a little bit more expensive than say just a standard piece of gauze. Kind of moving on to more larger amounts of bleeding. So you're thinking now about things like a tourniquet, and this is very effective for life-threatening kind of arterial bleeds. kind of in your extremities. So that is a 1A recommendation. If kind of the methods that we previously talked about aren't helping, you could consider a tourniquet as well. But knowing that you are, kind of really that a tourniquet is a little bit more kind of the extreme, kind of when all other measures are failing. And then a thing that they emphasized is not to kind of release it for kind of intermittent perfusion. So essentially once it's on until you get to the hospital or a place that can control the bleeding once you release it. And so kind of as this picture is showing, it goes kind of on, it's going to go kind of above the wound, so above the bleeding area. You're going to Velcro it tight, and then you're going to use that little winglass and kind of twist it until it's very tight, the bleeding is all stopped. And then you're going to want to put the kind of time that you applied the tourniquet on either that little white or kind of gray kind of little spot. So that way people know kind of how long the tourniquet has been on. Moving on to
another thing for the tourniquets that they recommend too is they say it can be a initial step in hemorrhage control while you extradite them and apply a pressure dressing and whatnot, and then you can remove it to see if your pressure dressing is appropriate.
We have to fix some things still.
So for lacerations, so kind of this is a way of kind of closing something acutely. When you have a very grossly contaminated wound, you might just want to pack that and kind of have delayed healing or secondary intention. For clean wounds, you can close them up to 6 hours. And for a wound that's on the face or the scalp, you can wait for 10 hours. Tissue adhesives can be a great form of helping a laceration close. And moist wound environment can be helpful with healing. And of course, using a clean protective bandage is kind of a great idea. For wound prep, the big thing here is that you're going to want to use clean water, so something that you would drink, and high pressure can help to lower the risk of infection using at least 1 liter. And sterility isn't really the most necessary thing. So really, you're just kind of going for a clean type of system. For abrasions, you're going to cover it with a non-adhesive gauze. So like this type of gauze, it kind of has that cottony inside, and then it has kind of that more smoother outside or plasticky type of outside. And otherwise kind of treating them similar to your lacerations. For friction blisters, they emphasize kind of good footwear, kind of a dry foot environment, wicking sock system. They give kind of a couple different suggestions, and maybe acrylic over cotton and using kind of a little bit of an undersock. There a lot of the common things like preventative moleskin, duoderm, kind of adhesive types, emollients, foot powders don't really have a lot of evidence for it. One study showed a reduction with aluminum-based antiperspirant, but essentially having that good footwear and kind of dry foot environment is going to be your key component. The other things that you can do if you have a blister would be to use kind of a blister kind of pad like a moleskin in a donut shape. So they either can come pre-cut, or if you have just kind of a flat one, you can fold it in half and make your own little circle that can then fit kind of directly over that hot spot or that blister that's forming. You can use like a hydrogel type of dressing as well, and that can help. For larger ones, they say that you could drain them, but not really unroof them. Kind of the key thing is that you don't want it to get infected, which is why they generally, for like smaller blisters, say don't drain it, as well as to keep that kind of outer skin covering there. And then if you don't have the hydrogel, you might have some petroleum or antibacterial ointment and just use that with some gauze. For burns, so cool water is going to be nice. Not only will it help to feel good, but kind of the big thing is to avoid kind of freezing the tissue. So cold water, not ice. Hydrogel has a little bit of better healing outcomes. And then biosynthetic and silicone coating dressings are preferred over the silver sulfadiazine. For escherotomies, so if you have a circumferential burn, so a burn that kind of goes through kind of all the way around a limb, or also considering the chest, which could impair ventilation, you're going to want to consider kind of cutting some spots into the skin, not really going super deep into the fat, to help release some of that tension so that you don't cause a compartment syndrome picture. And then kind of the little red areas are places just to be cautious with kind of your neurovascular bundle if you are going to perform this. For infection, if you have access to antibiotics, you should definitely consider that. If you have an open fracture, human bite, or any form of mammal bite to the hand. Burns don't necessarily need this unless it's showing signs of infection. And then kind of like we mentioned before, the sulfur sulfadiazine might increase the risk of infection and delay healing. In terms of using topical antibiotics, well, that has a 2C recommendation. So again, little harm, might help a little bit, but not super strong evidence or recommendation. And then finally for evacuation, so you're gonna want to do this, if you have a complex wound, open fracture, exposure of tendon, joints, nerves, blood vessel damage, mammal bites, signs and symptoms of infection or infection that's progressing without antibiotics. You have a large foreign body, especially if it's of organic material. You have the systemic toxicity, so your fever, altered mental status, shock, hypothermia, that crepitus or that gas that you're concerned about, tetanus, rabies, like we talked about, and then kind of significant devitalization of the tissue. And then finally for your burns, any airway or inhalation is definitely going to be very concerning. You have that large thorax wound and you can't really take those deep breaths in, and impairing ventilation, high risk areas, hands, feet, face, those circumferential burns, again, for the risk of compartment syndrome, 5% of full thickness or 10 to 20% partial thickness, any chemical, electrical, lightning, and signs of infection as before, and uncontrolled pain. So those are kind of the big kind of guidelines and highlights from the Wilderness Medicine's wound practice guidelines. What questions are there, or comments or other thoughts?
Anybody treated these conditions on themselves or tried to prevent them on themselves, or had experience treating them in the field? Is there anybody who hasn't applied a tourniquet? She talked about that briefly. Or like at least played with one?
I applied one once, or I believe twice, but not in the wilderness. I applied them as an EMT.
So, and like people in the WMS love to, or just wilderness medicine in general, love to say like, oh, we're in the wilderness, we gotta improvise and use whatever we got around us. Let's use whatever we can find. And yeah, at least an inch and a half wide belt, preferably not leather, would be great. But this tourniquet, this cat tourniquet she's showing in the both pictures here, is like $25, remarkably effective, very lightweight, very small, compressible. I just recommend keeping an actual production quality medical tourniquet. And you want to ratchet as much of the tension you can prior to doing the windlass. The windlass is like the final tweaking. And then you latch it down. You can write on that little white strip. It's like the gray strip here on the right, black one, and the white strip on the gray, orange one on the left. Or you can just, like Chris said, you can just write in Sharpie on their forehead the time you applied it. But they're, unfortunately, since the wars we've been fighting for the past 20 years, great studies show they're pretty safe if they're used properly.
One thing I've noticed with those is a lot of people carry them, but a lot of people like to don't ever open them and they keep them in the plastic packaging. But if it comes time that you need a tourniquet, you need it immediately. Like the 30 seconds to open it and get it ready can really change the outcome. So take it open, or open it when you get it, take it apart, put it back together the quickest way that you can apply it.
And I'd add to that a lot of times they don't come packaged in the way you necessarily want to store it. You want to store it in a one-handed configuration. So if you just go on YouTube, look up how to put on one of these tourniquet one-handed, that's how you want to store it in that configuration. So you can put it on one arm if you have one arm that's incapacitated.
Also, make sure that the tourniquet that you buy is reputable. There's been Chinese knockoffs and other various makes that I've actually broken just with standard application. So just make sure that you're looking cat tourniquet 7th generation, which is the gray strap on the right, or one that is TCCC approved. So just make sure you're getting a proper product before you just order something off of Amazon or eBay.
The orange one there, my service carried them. It was just on the ambulance, and I've broken at least 2 of them. So I just stole a screwdriver and used it to make it work. So it was tourniquet, and actually the comment there about the C-locks, packed the wound with C-locks and put another tourniquet, and it worked like a champ. Actually, I met the person years later and they kept their leg. I was very surprised, but it worked. That plastic does like to break though. So either metal ones or have a backup plan.
Definitely agree with what Blandon and Carver said. So the orange and the black are just different colors of the same, and North American Rescue is the company that produces the Cat Generation 7 tourniquet. And they also come in blue. So if you see orange, you see black, you see blue, doesn't mean they're inferior anyway. As long as it's North American Rescue, Cat Gen 7 is what you want. And the newest ones also come with the double bite configuration of the teeth. And you can reverse, in the old generations, you had to reverse the configuration so the teeth bit the opposite direction to apply to the thigh. It was just too large of a circumference for the general configuration to work. The new generation, it's good either way, good for arm or leg. Not junctional though. You need a separate device for like shoulder or like inguinal region. Anyway, has anybody held pressure for, like, let's say a central line's removed, art line's removed, or just for decent amount of bleeding? Did your fingers get tired? I'm sure
I used a blood pressure cuff.
You can do that. So you can do fingers because the goal is to do localized pressure, right? The goal is not to squeeze with your hand and hope for the best. It's localized pressure, stick your finger in the wound, or you take the heel of your palm here and just shove it right there. As you sit like this for a while, like that, your fingers are going to get tired. And I've done it myself. I didn't know this. I was a student. They're like, go take out that central line. I had never done it before, but you don't want to sound dumb. So I just took out the central line. By the end of 10 minutes of holding pressure, my fingers were exhausted. So imagine now you're in the field on the side of like a trail 10 miles from the trailhead and you're holding pressure. Your fingers are going to get tired. I would use like the heel of your thumb, like your thenar eminence right here if you have to. And then tourniquets, like she said, you don't jump straight to it unless there's obvious need for it. But it's life or limb. And if they're going to lose their limb from ischemia, it's better than being dead. So, but that's not the main thing here. Tourniquets are just a unique thing. Has anybody tried that 2 sock technique she mentioned for blister prevention? Did it work?
Yeah, I did the Inca Trail. I have the hiking socks, the little thin ones.
Yeah.
Fantastic. Not one even mention of a blister.
Yeah.
The only time I had them was wearing my Chacos. But then I had the Leuco tape, which is just super zesty cloth tape. And that stuff won't come off until you want it to come off. But the double sock works like a champ.
Does anybody know how to correctly apply Moleskin? It's not hard. Oh, she's showing it. It's in the picture. So you don't just cut a big wad of it and stick it on the blister. That doesn't help much. You leave the blister itself kind of exposed in the center, and then you cut around, so it's like forms a perimeter. And so the goal is to have like an equal height of the blister surrounding the site, and then so nothing's rubbing against it. That's the goal. And she mentioned adhesive, paper tape. You want to use paper tape, not like silk tape. Paper tape was, if you go to any WMS conferences, the Stanford group gives a lecture on it like every single year about preventing blisters. And their study shows that it protects all the skin underneath the tape, but there is increased risk of blisters immediately adjacent to the tape. So take that for what you will. All right, any questions for Kristen or any other points on just like the guideline kind of basic wound care stuff?
Just going back to the blisters, I think she has the picture there. I don't know what they're called, but they're amazing. And I always get a bunch of them and I bring them on my hikes and they're just incredible. They're like an extra pair of skin and you don't have to worry about cutting holes and things. You just slap them on. They're really nice.
Compeed. Blandon, what's a Compeed?
Yeah, Compeed's a commercially made product. It's pretty prevalent in all the pharmacies in Europe. It comes in a teal colored box. It's like a fancy Band-Aid, similar to what Jessica's describing there. They come in various shapes and sizes, but the intent is that it is a second skin, of lack of better terms. So it would go over even an already formed blister and provide a protective barrier. It's a pretty much, you put it on, leave it on, forget about it. You know, when you get out of the trail, get off the objective, it comes off. Yeah, I'd say it's pretty available in Europe, though, nonetheless. You'll see it in a lot of the European towns.
I think I might own some. I'm gonna have to go check my first aid kit, but Europe's, sorry for everybody else who's not from Europe. We're a little behind the times, and if you actually look at
well, hey, do remember I'm in Africa. I frequent Europe. So
yeah. Are you still on an oil rig?
Yes, I am. I got back this week. I just spent the last month in the French Alps, but yeah, I just got back onto the ship this week.
All right. Yeah, I've gotten to know a lot of names on this so far. Anyway, Kristen, thank you very much for presenting. Out of the journal article presenters, who feels ready to go? Anybody who feels prepped can take it away. And you should be able to share screen.
I can go first.
Okay.
So my presentation is a case study or a case report. If you guys can see that. So it's a case report for a river boatman out in Colorado who about 2 weeks into a 4-week trip got a 4 inch laceration on his lower leg. And it's just a review of how it was treated in the field and what could have been done better and what they did well. So, introduction. So national parks are having an increase in people every year. The wilderness is becoming increasingly traveled, and with that, wilderness injuries are becoming a lot more prevalent. The most common ones are traumatic wounds, specifically musculoskeletal wounds of the lower half of the body, are extremely common, especially in males. So that's what occurred here. About 10 years ago, the patient's name is Brad Dimmock. He, like I said, was an experienced riverboat captain. He'd been doing that for 30 years, which I think is a good example that these things can happen to the best of us. It's not just for your inexperienced amateur woodsman. And so this case just follows the treatment of his lower leg injury. On the right, you can see a map. I tried to mark the general idea of where these things occurred. So he was traveling from the top right down the Colorado River to the bottom left on Lake Mead. It's about a 4-week trip. And that's the amount of distance that was covered from the day of the injury until it got so bad that he needed to be evacuated. So just an overview of the medications we're going to discuss. So there's a Tegaderm transparent waterproof dressing. That's just like your typical, like a large Band-Aid that's clear so that it's waterproof. You can see through it. a self-adherent wrap. Some people call it like Coflex. It just attaches to itself. It's very good for working on injuries that are wet, because it'll still work with water, which paper tape and sometimes the plastic tapes won't do well with. A suture kit was present, and then lidocaine, trimethoprim, and sulfamethoxazole, povidone iodine solution, and azithromycin are all medications that were present and were used through the course of his treatment in the wilderness. And the ways that those act is listed below. So I'm going to go through the case. It's pretty much just follows a path from day 1 until day 8 when he's evacuated. So as I go through it, if you guys can just try to see some areas, and I'll ask at the end where things were done well, and as well as where things could have been done better by the team taking care of him. Let me see. So day 1, Brad was rushing, trying to load boats. They were at a halfway point where they were swapping out some passengers that had been on for 2 weeks for new ones that were going to go for 2 weeks, when he slipped and got about a 4-inch laceration on his shin, shown on the right. He applied pressure, which was able to stop the bleeding, but it still left a rather large open wound, and he began discussing with the other boatmen what they were going to do. So there we go. It's not moving right. So 2 passengers overheard this and offered to help. They happened to be physicians. So one was an orthopedic surgeon and the other was an anesthesiologist. Between the 2 of them, they happened to have a suture kit on them as well as some lidocaine. And they decided to close up the wound. They placed 6 sutures and wrapped the wound with the Tegaderm waterproof dressing and a self-adherent wrap to protect that and add some pressure. And then, so at the bottom, you can see them numbing the wound with the lidocaine, putting in the sutures. And then on the far right is the wound at the end of day 1 after being closed up. So days 1 through 4, relatively routine. Everything was normal. The wound was had the dressings removed repeatedly every morning and night, and they kept it clean from any visible contaminations. So night 5 is where it started to become a problem. So the wound started to get erythemic, painful, warm, your cardinal signs of inflammation. And Brad was started on trimethoprim and sulfamethoxazole. Antibiotics, those were both taken orally, is my understanding. And they marked the wound with Sharpie to see how much the infection was going to spread as time went on. The next day, the wound was stable, so they continued on, and they were optimistic that it was going to get better. So day 7, the redness got significantly worse, began to exceed the areas of the Sharpie lines, and his leg became increasingly swollen and red to the point where he was able to push on his leg and there'd be fingerprints left for a few seconds. And the team at this point decided that they could no longer handle what was wrong with him and that they were going to move to a site for evacuation in the morning. So that night, the stitches were cut and the wound was reopened to drain and clean it. And then it was packed with a povidone iodine impregnated gauze. And he was started on oral azithromycin to give him a stronger antibiotic to try to start fighting this. And you can see on the right that they used a water gun, I guess, that they had because they did not have a syringe to try to irrigate with the povidone iodine solution. And then the far right is how it looked when they were on their way to the evacuation site. So finally, day 8 from the day of the injury, contact was made with the National Park Service with a satellite phone at 5:35 in the morning. He was airlifted out by 10 a.m., landed at 10:45, and was then transported by ground to the nearest hospital. He got there at 12:30. At 2 o'clock, he was assessed, and they decided that it needed to be reopened and a debridement had to occur. That happened at 9 p.m. that night. So day 9, spent it in the hospital recovering. And on day 10, he returned to the OR. They closed up the wound and he was discharged with some antibiotics. And on the right, you can see that it healed relatively well with not much of a sign of it having ever happened at all. So looking back at this, infection was the primary issue that was being dealt with here. That's going to be hard to keep under control in the wilderness. So for fresh water, there were 3 major concerns brought up in the case report. So gram-positive species, coroniform and bacillus, those were a little bit easy to keep under control, and the antibiotics they had on hand would have done well against those. However, gram-negative species, the Aeromonas is very present in fresh water and a common contagion. So special concerns with that, it has resistance to a lot of antimicrobials, trimethoprim being one of them, which is probably why it was not doing so well for the patient Brad. And treatment for anyone with a suspected Aeromonas infection is to be evacuated and to start on broad-spectrum IV antibiotics as quickly as you can. The person writing the case report overall recommended treatment with oral levofloxacin and trimethoprim sulfamethoxazole, and that was found to be highly effective for most freshwater species when those 3 are given in conjunction with each other. Let's see. Okay, so does anybody have any thoughts on what the team did well or what the team did poorly, given all the information I've provided? You can either say it or throw it in the chat.
Seems with the equipment they had, they did what they could. It doesn't sound like they were smuggling any Levaquin with them to use. Yeah,
that's a good point. I also see that Tate brought up that it was innovative to pack a water gun. While they probably didn't plan on that, it was innovative to think of that when they needed to irrigate and have the resourcefulness to use it. So the mistakes that were listed in the case report, so they failed to initially irrigate the wound prior to closure on day 1. Which goes along with the second one. They failed to recognize the wound contamination by the river water. So while river water may look relatively clean, the thoughts here is that if it's not potable and you wouldn't just dip a cup in it and drink it, then it should be treated as infectious as just as equally for open wounds, and irrigation needs to be performed. It also said that shaving of the area around the wound, while effective pre-surgery, is not found to be effective post-injury with open wounds like this, and can actually be worse and introduce more infections to the area. So the primary thing that was addressed is that the providers used their surgical expertise, being an orthopedic surgeon and an anesthesiologist, to close the wound without considering leaving it open, which would probably have been best in this case. And the key takeaway there is that while we are all trained very well in whatever it is we do specifically, or whatever, if you're a physician, whatever your specialty is, that doesn't mean that it's going to translate perfectly into the wilderness. So these two, very used to having open injuries, they close it up with sutures and they send them home with some antibiotics and everything goes well. They didn't consider contamination because in the surgical wing, you have your surgical field, and it's not really, contamination is not a huge issue like it would be in the wilderness. And then finally, so excessive irrigation on day 7 was actually listed as a mistake because the povidone iodine solution is a tissue toxic solution. So it will kill both eukaryotes and prokaryotes, which means that it's going to kill his healthy tissue around, making it a little more difficult for everything to get together. And beneath, there's a couple things listed that also have this tissue toxic effect. So one thing that they did well, the 3M Tegaderm transparent waterproof dressing was very good because it allowed the wound to heal in a moist environment. Like the last presentation mentioned is good for open wound healing. It was protected from other infection sources, and the transparency of this allows the wound to be monitored without removing the dressing and opening up the possibility for more infection to occur. So the author made 3 recommendations. So first, they recommended using wet to dry dressings and delayed closure for large high tension wounds with controlled bleeding. But if the bleeding is uncontrolled, they said that sutures can be utilized and usually should And they recommended that anytime sutures are being used, evacuation should be highly considered and antibiotics should be a must. So most attention needs to be placed on determining if the wound is complicated or uncomplicated. So just because the wound may not look like it's infected or may not look dirty, you have to consider how it happened and where it happened. So in this case, it hit the boat and was in the water. So the water is a source of contamination. I'm sure that the rafts that they use through the water aren't clean either. So it kind of has to go off the assumption that it's infected with something or contaminated with something. And then finally, so research shows small differences in the healing of small wounds, whether you choose to use sutures, tissue glues, adhesive strips. So for this case, it was 4 inches, which is obviously larger than that. So sutures were the best move once closure was determined the best option. But anything small that most of us will get in the woods, all 3 of those are good options. So the conclusion that the case report found was that there's a need for a systematic approach to evaluating and managing wilderness injuries. And those need to be made clear to providers across the board of all specialties, because their specific expertise and standard of care routines aren't always applicable to the wilderness environment and can, in some cases like this one, be detrimental. So furthermore, infection has to be closely monitored, even in minor trauma. Your little 1 centimeter cut is not a big deal, but if it gets infected, it can lead to an evacuation being necessary. So don't underplay any wound that happens. So my personal takeaways from this: so rushing is never a good thing to do in the wilderness. Whenever you rush, mistakes happen. Brad had been doing this for 30 years. And the 5 minutes that he saved by rushing to try to get those new people on the boat didn't really help anything out when he then had to be evacuated 8 days later. So take your time. Communication was huge in this. So if they had not had the satellite phone, it would have been another week before they were able to get him any kind of treatment, because they wouldn't have had contact with anyone. So even on your simple trips, if you're going to be outside of cell phone service, communication devices are to be highly considered. Resourcefulness, what I was mentioning with the water gun. So use what you have to your advantage and think of new ways that you can use what you have. And then finally, I think the biggest takeaway is consider how long it's going to be from deciding that you want to evacuate someone to them actually receiving the care that they need. So in this case, from the decision to evacuate Brad to the time he was in the OR getting what he needed was 29 hours. A lot can happen medically for someone in 29 hours. So consider where you are, consider where the nearest hospital is, how much time it's going to take, even weather can affect that, and take those into consideration when you're deciding whether or not someone can push through or whether they need to go. Any questions?
And back to your slide regarding they call it the shortcomings. So it said lack of initial irrigation, but at the bottom it also is discussing iodine. Was an ideal irrigation solution discussed, or was that just pretty much anything but nasty river water?
I think that was the understanding. They did not specify if any better irrigation solution was there, but I guess the point that the author was trying to make was, while it wasn't great to use this tissue toxic solution down the road, it might have been kind of the lesser of two evils to have done it initially and taken out the infection, even if it would have done some minor damage to the tissue.
Makes sense.
So the WMS guidelines that we just went over, they recommend potable water over any solution containing iodine or chlorhexidine.
Well, that's perfect, because everybody should have potable water. All right. If anyone has any other questions, let me know. These were the references. The case report was in the email if you are interested in checking it out. And other than that, I just looked up some things on the mechanisms of action for the different medications.
Other than what we just talked about, would anybody have done anything different if you were on the boat with him?
Would you have wanted to start antibiotics kind of as soon as you had to do it, just if you knew you were going to continue on and it was going to continue to be exposed to the elements and the risk for infection is higher?
I think if I had them, depending on what trip I was on and what capacity I was involved, I probably would have. I mean, dirty water, exposed to that dirty water every day with extended multi-day trip, I'd say I probably would personally. Do I take antibiotics when I go on my own fun trips for my groups with the fellowship group? No, I don't. If I was expedition officer or medical support, I totally would. It's kind of on your own. What level are you involved with the group though?
I think the length of the trip definitely affects it. Like in this case, they were like the boatmen specifically were going to be gone for 4 weeks with no real access to anything.
Right. If you're going that long, yeah, you better be bringing some stuff. But yeah, Carver made the good point. It's just potable water is all you need. Like I was probably the last generation of med students who was taught like you need sterile field, you need surgical sterile gloves, super sterile technique, sterile saline for suture, like simple linear minor laceration repair with sutures. Nowadays, I just have the patient put their own cut under the water of the sink, and I use whatever gloves I find. It's the solution to pollution is dilution. So if it's potable water, you flood it. You can use pressure irrigation if you need to. It doesn't have to be sterile. So if it's safe to drink, it should be safe to clean out your cuts or your wounds of whatever kind. But yeah, river water, it's like you would have to be in some remarkably isolated part of the world, which probably doesn't exist anymore. Like I don't know where everybody lives, but Appalachian Trail, like it's disgusting. Like you get your water sources from there, you better have at least 2 methods of disinfecting your water supply, and that's just a drink. Same standard essentially for cleansing wounds. I think the key point is the duration of the trip, what continued exposure there is, the time from wound to potential repair, and like how severe of a cut is it? Like, does it truly need sutures? Can you do steri strips? Can it just be a gauze bandage? Because suturing when you don't need suturing doesn't help. But yeah, this was a decent cut.
And steri strips are awesome backcountry thing because they weigh nothing. They're easy to put on. You can put them on in any situation. They're cheap.
And I keep the little Tegaderms you use for like IVs, which are like, I don't know, this big. But I think with this story, I might start keeping like the larger central line dressing size Tegaderms. I might stash a couple of those in my kit too. Just as effective, larger area. You can visualize the area. It's essentially waterproof. That's a kind of a cool idea. So whenever you read this kind of stuff, just think about cool things you can do. Bring a water gun, bring in your first aid kit. So obviously it's not a recommendation. That's for fun, but improvise when needed. All right. Any questions on the case or similar situations?
Yeah, I got a question. So if we were to hypothetically leave this wound open, and with this guy being on the boat for, who knows how much longer, what would be the method like to keep this wound clean, keep things out of it? Like what would be our way of like preventing microbial growth inside this wound?
Probably like a wet to dry hydrogel dressing initially.
Okay.
I mean, either way, it's going to be exposed.
Right.
And when you take the wound and you seal the top,
you're trapping everything
that was in there is trapped inside. Right. So that's the argument to not do sutures. I mean, from a personal standpoint, you got this patient who's like a psychological standpoint, who sees their cut, they're going to be like, oh my gosh, why aren't you doing anything for my big cut? And from a provider standpoint, you're like, I should probably fix this. But you just kind of think like exposure risk, closing it versus not closing it. How bad is it bleeding? It's situation dependent, very much so, I'd say. But I like in this person, they're going to be physically active. They're going to be on this raft or whatever activity they're doing. They're going to be moving the joint. Every movement's going to like prevent and delay healing. So that's tough. That's a tough call. And I think it could be argued either way. I think just because this had a cellulitic development doesn't mean they did the wrong thing.
Right.
I'd say it means like maybe clean it up a little bit better first.
Yeah. Thank you.
Yeah, if you're going to be on a raft, jumping around, falling without sutures, that cut's not going to heal at all.
Right, and it's probably going to open more. So
yeah, it's tough. You get a handful of like surgeons and dermatologists and ER docs, and you have them talk, and I bet it's going to be like 50-50. So,
yeah. Cool.
All right. Other than that, whoever else feels ready to go, take it away.
We'll go.
In honor of the squirt gun.
In honor of the squirt gun. We're talking about irrigating wounds, so I think it kind of lines up well.
All right.
In ways to be creative.
Can you guys see?
I don't know how you're sharing your screen, Jess, but
can everyone see that?
We're good.
Cool. Great.
Alrighty. You want an intro?
Sure. I'm Jess Brimbaugh. This is Nick
I'm
Wilson. We're second-year medical students at WVSOM, and we're here to present the journal article, Pressure of Wilderness of Improvised Wound Irrigation Techniques. How do they compare? So we'll get started.
So the big takeaway with this is that traumatic wounds are very, very common, just like our last case presentation. Annually, there's roughly 10 million ER visits that involve some type of acute wound that might be a laceration. And what we want to do with these wounds, if we are going to irrigate them, the goal is to remove debris, bacteria, and dirt, and ultimately prevent that infection. So what can we use in the wilderness that we might have in our pack if we don't have this commercialized kind of like shielding syringe per se? So this article or this journal looks at using water bottles, hydration packs, and plastic bags as alternative means to irrigate a wound. And just like the last case study, they used a squirt gun. So that was pretty interesting. And they're looking at a previous model. So they're comparing. So they kind of had an issue with how do we kind of keep things consistent? And the group that they were looking at or kind of balancing their paper off of, they used a benchtop model with pressure in a closed system. And they used inline pressure gauges and devices to kind of measure the, I guess, the PSI of their, what are they called? I'm blanking on this, on the irrigation device. Sorry, guys. And the issue that they had was it being credible, and there's multiple areas of variation and data collection errors. So the goal for this paper was creating a reproducible model using fluid mechanics equations and being able to compare that to things that you would find out in nature and a commercial device. Just how do I advance this? All right, so the study design is right here on the left, we have this splash guard, which is a commercial product. It's a 500 ml syringe, and it has a little splash shield on it. And what you do is you kind of just stick it on the wound and you irrigate it. And so then what they looked at is kind of moving over to the right, that they were looking at a 10 ml syringe that either had no needle on it, so like a catheter, or just an open syringe. There was a plastic bag, a water bottle with a hole in it, a sports drink, like a smart water bottle that already had a pre-made hole in it, and then this hydration bladder. And then the last one that they looked at was the Sawyer syringe that was a 50 milliliter syringe. So the study design was that they would take each of these devices, they'd fill them to the max capacity with water, and what they would do is they'd put them on a level bench and they would eject the water out of these devices, and they would measure it with a camera, the speed or the velocity at which the water came out and the height. And what they did is they calculated the difference, and they ended up finding the PSI at which these different devices were able to irrigate at. And so here's just kind of like the design here. So the height, and then they squirted it off the bench, and they measured the stream height and how much it displaced from like when it impacted the glass to where kind of like the flow trickled to. And that was the mean, the minimum height. And they averaged that to get a like an average range of basically just pressure that they were calculating over that area. What they did for every device, they repeated this 5 times to get that PSI that they needed to compare it to the commercial device. So for data analysis, they used they took the 5 measurements that they collected, and they put it into a projection motion equation, and basically calculated, like I said before, the PSI to compare it to the commercial device. And is that it, you want?
Yeah. Okay. All right. So for each of the trials, they were actually pretty consistent across the board. So for each of the devices, they did it 5 times, and they found that pretty much they were the same the whole time, which was great for them to see that they were being consistent. And then the only thing was it varied the most between the smallest devices versus the larger ones. All right, so these are all of the nitty-gritty numbers that they got, but essentially what we want to focus on is the splash guard. So that's, you know, our trauma center level irrigation. This is like kind of our goal right here. And so we got a max PSI of 4.9 and then a min of 4 or so, and then we can compare them across the board. And we found that the 10-liter syringe plus a syringe with the catheter and the water bottle, just like a regular water bottle with the holes, the 14 gauge holes, they were significantly higher pressure than even the splash guard. And then something that was closer to it was the Sawyer, so that water filter, and then the water bottle with the sports top, kind of like the ones that, you know, the Gatorade ones that people drink. And then significantly lower was a Ziploc bag that they put holes in, and the water bladder, the ones they put in the backpack. So yeah, so it's pretty significant. I don't know if Nick didn't mention it, but essentially what they did was they had someone literally manually squeezing these things, and it was the same person for all of them. So there's a lot of stats that they did to figure everything out, and honestly, I don't understand it, but just so you know, they were going to do the significant difference with the p-values, but because of homogeneity of variance, they couldn't actually do it. It violated it. And then there was a Kussmaul-Wallace test to support the significance in the differences, and then a Turkey's Honest Significant Difference test, which I would love for someone to explain to me, but I don't understand. So that there were different pressures upon compression and things like that. So to our discussion. The results were consistent with previous research with using similar models, which was really cool to see. And they have a figure here to the right that showed another research article, which has the black lines, and then their results, which were gray. And then that dotted line is the safeguard standard. That's the goal. So that was really cool for them to see, because a big thing that they were asking was, you know, is this research approach, or is it something that is financially feasible? Is it something that's reproducible? And so it was great for them to see that their methods are aligning with other results. The only thing is the variability in the type of water bottle. So their water bottle was like a harder one versus like those like super thin water bottles that, you get at Walmart and then you like squeeze. So that can have some subtle differences. Some things though for future research is this question of what pressure is ideal for irrigation of acute traumatic wounds. So, is it ideal to just use the splash guard level, because then our syringes and our water bottle hole is way higher in pressure. And so is that going to cause more damage potentially to our wound? And so it kind of comes all down to that. And right now, the American College of Surgeons has a standard of, super high is 35 to 70 PSI and low is 1 to 15. And then the Wilderness Medical Society is a high of 6 to 15 and is a low of -6. So, sorry, less than 6. So it's pretty substantially different than the College of Surgeons, but anything above 15 is high. Continuing a little bit on there. So essentially the consensus was that there's benefits to wound irrigation are just time dependent, and the sooner the wound can get irrigated, the better. And then additional comments were made in their discussion to talk about, the Ziploc and the bladder hydration system just did not meet the commercial standards that they were hoping to look at. And there was no reference to how much irrigation, how much fluid or how much water they gave. And then the limitations was also, they had the one person squeezing everything at the same time. There's grip strength variability. You get some weaker person trying to do it's going to be a lot different than some, rock climber that's like squeezing the heck out of a water bottle. And then again, finally, the conclusions. So they concluded that the water bottle method, specifically the sports water bottle with that smaller head, is the best. It exceeds actually the commercial device, but it works. The Ziploc plastic bag with the holes and the bladder hydration system failed to exceed the commercial device PSIs and then would not be recommended. However, they did find that there are some research articles that said it really doesn't matter, and that, as long as you're getting water in there and clean water in there and you're doing what you can to irrigate it, it doesn't really matter if it's some super high PSI. So there is some conflicting results on that. But ultimately their recommendation is, carry, these kinds of equipment and you guys will do great when you're out there in the wilderness. But ideally, if you can maybe have the sports water bottle, something that you can really pressurize behind it and squirt a decent amount of clean water. Like we just said earlier, that something you can drink is best, and you'll be set to go. So yeah, do we have questions?
I guess with the irrigation pressures they were mentioning with the different devices, is anybody going to change what's in their bag or their first aid kit?
Probably not.
I always keep 10 cc syringes in my kit, so I'm good to go.
Right, and that solution's clean. It's not, not going to have any contaminants in it. So,
yeah.
Oh, one thing I did want to mention that they talked about that I thought was a little questionable was, okay, so you have a water bottle and they say poke all these holes in it, and then you can use it as an irrigation. It's like, okay, well, how are you going to poke the hole in it? Now they used these syringes.
They used a 14 gauge.
Maybe you don't have a syringe, or you can use a nail. So that might be a little bit difficult. But then they were like, but it's versatile, because then you can use it as a bidet in the woods when you don't have like toilet paper. And I was like, so we're going to use what we use as a bidet to also irrigate our giant wounds. I don't know. I wouldn't particularly want to do that, but.
I use the splash guard to the left, and it's in every ER or probably urgent care you'll see. But I also do a mix of just kind of flooding the wound with clean water and pressure. You got to get the small particles out. You got to get it just generally clean. It's nice to know that, like with this 10 cc syringe with the 14 gauge or just a Gatorade sports bottle, it's good enough. That's pretty remarkable, actually. I wouldn't have guessed that it was going to get such good pressures.
Yeah, I was pretty impressed by the PSI that it put out. So
Yeah. The splash rate is just nice from like a wound care standard that as long as you're doing it right, the goal is to not, splash. You don't get nasty wound contents around the room or in your face. That's what I use it for primarily. But
right.
Yeah, I think it's just kind of cool. So you were mentioning drilling a hole with a 14 gauge needle. I have seen people do it. I have had people tell me to do it. Has anybody tried to do it and saw that it was like easily done?
Are you talking about in the water bottle?
No, in like, let's say you got to, sorry, from like a clinical setting, urgent care, ER, hospital, you take a 14 gauge needle, you take the top of your sterile saline or sterile water, and the people tell you to like drill into the cap. Has anybody done that?
It's not.
I have done it and it did not work well for
a nightmare.
Trying not to stab myself.
Yeah, sure. You can take your Swiss Army knife there, but yeah, Lindsay, I agree. Like I held my sterile water cap and I held my 14 gauge. I was like, I'm not doing it. So if you have like a soft plastic or a other type of lid, sure. But if it's like a rock solid plastic lid, like Gatorade lid, yeah, you'll go straight through that. But
are you talking about that thick thing on top of the sterile water bottle?
Yes, people say to do that, and no, I don't think it's feasible. I don't think it's safe for yourself. But yeah, if you're taking a regular container, I think a 14 gauge will drill through that. But just remember, like your own safety, whether you're in the ER, clinical, whatever clinical setting you're in, especially in the wilderness, your safety comes first. Your employer and your insurance company might not agree, but
actually, I kind of remember eons ago, like on my first clinical rotations ever in like 2010, they told me go clean this wound out, and I kind of gave him this is my first day, what do I do? And he takes a needle, picks up a sterile bottle, takes a needle, sticks it in the side, and goes squirt it with this till it's clean.
Yeah,
he didn't even do the top. He just did the side of it up where it's kind of sloped. Said just use that until it's clean.
Yeah. I used to take like 2 liters, and depending on the cut, I still do. But yeah, never take the approach of one size fits all. It's variable, situation dependent, resource dependent. So I think this was just kind of cool to see. Like we probably have most of this stuff.
Yeah.
So, any other questions about this one or what you've done in the past? All right, I think we're ready for our last article. Sorry, my dog's getting needy. Back up. Who else? See, John went, Jessica, Kristen. Anybody? Who else is our presenter to the night? I'll pull up my email real quick to recall. Oh, he's not here. I'm not seeing our final presenter. Okay. That's fine. Yeah, our final article is our presenter is not here. Did anybody read the article and feels pretty confident in covering the topic by chance? It's on prophylactic antibiotics. I think that's okay. Rather than have somebody just scramble and kind of bumble their way through, it's a pretty dense article, and I think somebody just reading it, nobody would gain anything from that. Not every session has to last a full 2 hours. That's fine. Anyway, we had 2 good articles as well as thorough discussion of the guidelines. So any other tips on what you've seen in the past or any questions for what we've covered so far? Okay. Well, in that case, I'll consider this like formal journal article discussion completed. So thanks everybody for joining. I'm to end recording. Doesn't mean the session's over, just means the formal WMS recording is finalized. So thank you.